Welcome back to Radon's Smart Review, Thoracic Edition. Today we're getting into something that is incredibly complex.
Yeah, to put it mildly.
Right. We're looking at the world of superior sulcus tumors, and specifically the trimodality therapy used to treat them.
It's a really high-stakes topic. Treating a tumor at the very top of the lung, it isn't like treating a tumor anywhere else.
Exactly.
You're operating in this tiny anatomical bottleneck that is just packed with critical structures. The margin for error is essentially zero.
Yeah, so our mission today for you, the listener, is to figure out exactly what dominoes need to fall before a patient can safely go down this really intense pathway of chemo, radiation, and surgery.
Right. We need to map out the anatomy, the physics, and the biology of all these decisions.
And to keep it grounded, we're going to use an anchor case today. I mean, this is the exact scenario that makes a tumor board go totally quiet.
Oh, absolutely. Everyone leans in when this case comes up.
So you've got an adult patient in your consult room. They have a biopsy-proven non-small cell lung cancer rising right at the lung apex.
Okay, classic presentation so far.
And you pull up the initial contrast-enhanced imaging. It shows chest wall invasion. And on top of that, there's possible extension heading toward the brachial plexus and the subclavian vessels.
That is the terrifying part right there. The tumor is basically knocking on the door of the nerves that control the arm and the major blood vessels.
Yeah, but let's look at what else we know. So far, no distant metastatic disease, no brain mets, no bone mets.
Which is good, but what about the mediastinum?
So the invasive mediastinal staging hasn't been completed yet, and the pulmonary evaluation is still pending.
Okay, so a lot of unknowns.
Exactly. You talk to the thoracic surgeon, and they're being super cautious. They think an en bloc lobectomy might be feasible, but they need an MRI to be sure.
And let me guess, pneumonectomy is still on the table.
Yep, they haven't ruled out taking the whole lung.
See, so the consult question you're going to get isn't just, hey, should we do chemorads and surgery?
Right, it's way more specific than that.
The real question for you to answer is, does this specific patient actually belong on a curative trimodality pathway? And what exactly has to be settled before you even turn on the machine for fraction 1?
So let's start by defining the disease itself, because people throw the nomenclature around very loosely. And we need to be precise.
We really do.
Just because a mass is located at the top of the lung,
Yep.
An apical location that does not automatically make it a superior sulcus tumor.
That is such a fundamental distinction. Location creates the suspicion, but it's the invasion that actually defines the disease process.
Right.
I mean, the superior sulcus is basically just the groove made by the subclavian artery as it passes over the first rib. For a lung cancer to actually be a superior sulcus tumor, it has to physically invade the chest wall or those thoracic inlet structures.
So if it's just sitting in the upper lobe, totally surrounded by healthy lung tissue.
And then it's just an apical lung cancer. It's not a superior sulcus tumor.
Yeah. Okay, that makes sense. Let's unpack the anatomy a bit more, because you really can't stage this without knowing the local geography. You constantly hear the term Pancoast syndrome.
Right, named after Henry Pancoast. He was a radiologist who described these tumors way back in the 20s and 30s.
Right, and it's this classic clinical triad. You've got shoulder or arm pain. You've got brachial plexopathy, which usually shows up as hand weakness. And you have Horner syndrome.
And those symptoms are basically just a map of where the tumor is invading.
Let's drill into the why of those symptoms. So the shoulder pain, that's because the tumor is eating into the parietal pleura, right?
Yeah, pleura, the first or second ribs, the intercostal nerves, that causes severe pain.
And the hand weakness.
That's because it's invading the lower roots of the brachial plexus, specifically the C8 and T1 nerve roots.
Wow, okay. And then Horner syndrome, which I think is probably the most fascinating clinical clue.
Oh, absolutely. It's so strange when you first see it.
You've got the drooping eyelid, the constricted pupil, and the lack of sweating on one side of the face. Why does a lung tumor do that to your face?
Right, because the tumor has invaded the stellate ganglion. It's this bundle of sympathetic nerves sitting right at the level of the first rib.
Ah, okay.
Those nerves travel up the neck to control the eye muscles and sweat glands. So when the tumor crushes that ganglion, you lose that sympathetic fight or flight input to that side of the face.
It's an incredible clinical puzzle, but there's a massive trap here for anyone evaluating this patient. Pancoast syndrome is just a clinical syndrome.
Exactly. It's a set of clues.
It is not a substitute for a tissue diagnosis, and it is not a formal stage. A patient can have a true superior sulcus tumor without the full Pancoast syndrome.
Right. They might just have a little shoulder pain. And on the flip side, a patient with a droopy eyelid and arm pain still needs an anatomic and pathologic explanation.
You can't just prescribe 45 gray of radiation because their eyelid is drooping.
No, definitely not. Symptoms don't dictate the dose. Tissue and anatomy do. Which brings us to the AJCC version 9 staging system.
Yeah, let's break down the T categorization under version 9, because the line between T3 and T4 is razor thin, but the clinical implications are huge.
Huge. Under region 9, T3 means the tumor invades the chest wall, like the ribs or intercostal muscles, or the first or second thoracic nerve roots.
Or that stellate ganglion we just talked about.
Right, and it's T3 because, practically speaking, a really skilled thoracic surgeon can still remove those structures and block.
So they can take out the upper ribs, the lower nerve roots, clear the ganglion, and the patient survives with a functional arm.
Exactly. But if that tumor reaches just a fraction of an inch further, everything changes. It becomes T4.
So what pushes it to T4?
If it invades the subclavian vessels or the vertebral body, the spinal canal, the cervical nerve roots above C8, or the more distal brachial plexus.
Basically, the structures you can't easily cut out.
Right. If you hit a vertebral body, the surgeon has to do a vertebrectomy. They have to remove part of the spine, put in hardware, stabilize it. The morbidity goes through the roof.
Or if it's the subclavian artery, you're talking about vascular bypass and reconstruction.
Which is exactly why you can't just accept a vague radiology report that says something like apical extension. You need specifics. Is it hitting a neural foramen? Is it touching a vessel?
Well, let me push back on that a bit. In the real world, radiology reports are rarely that perfectly definitive.
That's true.
Like with our anchor patient, the CT scan report says the tumor abuts the subclavian artery. Does abutting automatically mean it's T4 and unresectable?
No, and you have to be super careful with radiology vocabulary here. There's a big difference between radiographic suspicion and pathologic proof.
Right, like the difference between abuts and invades.
Exactly. When they say it abuts a vessel, it just means there's no visible fat plane between them on the CT. They're touching.
But touching doesn't mean invading.
Right, it might still be encapsulated. A specialized surgeon could open the chest, find it's just leaning against the artery, and cleanly peel it off.
But the reverse is also true, right? You could have this subtle neural foraminal extension crawling along the nerve root into the spine.
And a standard CT scan simply doesn't have the soft tissue contrast to see it. It's completely invisible.
Which perfectly transitions us to the workup. To make sure you don't miss those microscopic extensions, you need a foolproof checklist.
You really do before you even think about starting this grueling trimodality pathway.
And according to our sources, there's a great mnemonic to help organize this. The MIND checklist. MIND.
It's the perfect mental scaffolding for a tumor board. Let's walk through it.
Okay, so the M stands for MRI. Specifically, a dedicated, contrast-enhanced MRI of the thoracic inlet and the cervical and thoracic spine.
And I want to emphasize, this isn't just a fancy add-on. It's an absolute requirement.
Let's explain why from a physics perspective. A CT scan uses X-rays, which measure density. Bone is dense, air isn't.
But nerves, muscles, and tumors, they all have very similar densities on a CT. They just blend into this gray blur.
Right. But an MRI uses magnetic fields and radio waves to map water molecules. The soft tissue contrast is just night and day.
You need that MRI to see those millimeter-level surgical planes. It tells you if the tumor is just pushing against the plexus or actually invading the nerve sheath.
Which totally dictates the surgical plan. And for us in radiation oncology, it shows us the serial structures we have to protect, like the spinal cord.
Exactly. So that's the M. Moving to the I in the MIND checklist, it stands for invasive mediastinal staging.
We'll dig into the nodal gate in a second, but basically you have to aggressively rule out N2 or N3 disease.
Right. A PT scan alone won't cut it. Then the N is for neurologic baseline exam. This one gets overlooked all the time.
Oh, totally. Why is a physical exam so critical when we have all this advanced imaging?
Because 6 weeks from now, when the patient is recovering from chemoradiation, they're going to come in and complain that their hand feels weak.
And if you didn't establish a baseline grip strength on day 0, you are completely flying blind.
Exactly. Is the hand weakness from the tumor progressing? Is it from localized radiation edema? Or is the nerve permanently damaged?
You can't distinguish treatment toxicity from treatment failure if you don't know where they started.
Exactly. And finally, the D in MIND, definitive fallback plan. You need a fully dosed plan for definitive chemorads locked in before you start, just in case surgery gets canceled.
We'll definitely talk about the mechanics of that fallback plan shortly. But let's circle back to the I, the mediastinal checkpoint. Our sources are very strict about the nodal gate.
Very strict. To understand why, you have to look at the biology of nodal staging. N0 is no lymph nodes. N1 means it's spread to nodes within the lung or the hilum on the same side.
Right. And N2?
N2 means it's spread deeper into the mediastinum around the trachea and aorta on the same side. N3 means it's crossed the midline or gone up to the collarbone.
The reason we care is that the reference trimodality pathway is explicitly designed and proven only for N0 or N1 disease.
Right. If you have proven N2 or N3 disease, it completely derails the surgery-based pathway.
Because it means the cancer's biological behavior has fundamentally changed, right?
Exactly. It's traveling through the lymphatic system. If it's in the deep mediastinal nodes, there's a huge statistical probability that microscopic cancer cells are already circulating in the bloodstream.
So doing a massive, brutal operation on the lung apex is just closing the barn door after the horse is bolted.
Yeah, it shifts them entirely into a stage 3 framework where definitive chemoradiation with immunotherapy is the standard of care, not surgery.
Okay, so let's look at our anchor patient again. Say they get a PET scan and an N2 node lights up. It's hot.
Okay.
The pulmonologist goes in, does an EBS, an endobronchial ultrasound biopsy, and it comes back negative. Are we cleared for surgery?
No, and that is one of the most dangerous moments in the workup. You can't just average out a hot CT scan and a negative EBUS and declare the mediastinum clean.
Why not? The biopsy is negative.
Think about the mechanics of an EBUS. You're driving a tiny needle through the trachea wall into a lymph node using ultrasound. Did you sample the right node? Was there enough tissue?
Or did the needle just hit reactive inflammation right next to the cancer?
Exactly. The false negative rate is high. If the imaging is highly suspicious, a minimally invasive negative sample isn't enough to dismiss the PET scan when a massive operation is on the line.
So what do you do?
You might need surgical confirmation. The surgeon might have to do a cervical mediastinoscopy where they make an incision and actually pull the whole node out for pathology.
The pearl here is that imaging impressions and pathologic findings are different types of evidence. Know which one you're relying on.
Absolutely.
All right, assuming we clear the mediastinum, let's say they truly are N0. We hit the next checkpoint. Medical operability versus anatomic resectability.
Yes. People say a patient is operable all the time, but it's a dangerous shorthand. It conflates two completely different clinical judgments.
I really love the mechanic versus chassis analogy for this. Let's break it down. Anatomic resectability is all about the mechanic, the surgeon.
Right. Does the mechanic have the technical skill, the tools, and a clear path to safely remove the tumor with R0 margins?
And just to remind everyone, R0 means zero microscopic tumor left behind at the edges. R1 is microscopic tumor left. R2 is gross visible tumor left. The goal is always R0.
So resectability asks, can the mechanic achieve R0? Medical operability, on the other hand, is about the chassis, the patient.
Can this patient's heart and lungs actually physically survive the operation the mechanic wants to do?
Both answers have to be an unequivocal yes. You could have a tumor that's perfectly resectable, but the chassis is a heavy smoker with heart failure who will die under anesthesia.
So they are anatomically resectable, but medically inoperable.
Right. Or you have a 45-year-old marathon runner, perfect chassis. But the tumor has invaded 3 vertebrae and encased the subclavian artery.
Medically operable, but anatomically unresectable without killing them on the table.
Exactly. And this gets us into the grueling weeds of pulmonary physiology. Because a lobectomy and a pneumonectomy are not just interchangeable items on a menu.
Let's talk about the mechanics of breathing after these surgeries. With lobectomy, you're just taking out one lobe, say the right upper lobe.
Right, so the patient still has the right, middle, and lower lobes, plus the whole left lung to breathe with.
But if the tumor is huge or near the hilum, the surgeon might have to do a pneumonectomy. They clamp the main artery, the main bronchus, and take the whole lung.
The physiologic demand of that is staggering. You instantly lose roughly half your capacity to exchange oxygen.
And your heart. The entire right side of the heart, which used to pump blood into 2 lungs, now has to force all that volume into just 1 lung.
Exactly. The pulmonary artery pressure spikes massively. A patient who could easily survive a lobectomy might go into right heart failure and die from a pneumonectomy.
Which means pulmonary function tests aren't a generic pass-fail. You have to do the math based on what lung tissue will remain after the specific surgery.
And this leads right to what I call the attending question. You're in a tumor board. The surgeon says the tumor is borderline. Let's do induction chemoradiation and see if it shrinks.
Yeah, that happens all the time. Let's see what happens.
Right. But you have to stop the room and ask, if this tumor only responds modestly, what specific operation are you actually going to do?
Because hoping the tumor magically melts off the spine isn't a medical strategy?
No, it's not. If the surgeon can't articulate a realistic path to an R0 resection under a modest response scenario, then you aren't doing preoperative therapy, you're doing definitive therapy and just pretending.
So if resectability is genuinely uncertain, get a second opinion from a high-volume center before fraction 1. Don't wait until you've delivered 45 gray to realize you're stuck.
It is infinitely easier to change your plan before you start radiation.
Okay, let's assume all the stars align for our anchor patient. N0, medically operable, realistic R0 lobectomy planned. We enter the Trimodality framework.
Which means preoperative concurrent chemoradiation, prompt surgical reassessment, resection, and then post-op systemic therapy.
And to understand why we use this exact sequence, we have to look at the evidence anchor. Southwest Oncology Group 9416, also known as Intergroup 0160.
Yes, the Bedrock trial. It was a phase 2 program looking at potentially resectable T3 or T4 N0 or N1 superior sulcus tumors.
And the regimen was concurrent cisplatin and etoposide alongside 45 gray of preoperative radiation over 5 weeks, then surgery.
I want to dig into the biology of that regimen for a second. We often just list drugs, but why cisplatin and etoposide? And why concurrent with radiation?
Let's do it. It's all about biological synergy, right?
Yeah, cisplatin is a heavy metal compound. It enters the cell and literally cross-links the DNA strands together. The DNA physically can't unzip to replicate.
And etoposide is an enzyme inhibitor. It blocks topoisomerase II, which usually untangles DNA during cell division.
Right. Then you add the radiation, which physically smashes the DNA, causing double-strand breaks.
So radiation breaks the DNA, cisplatin glues the broken pieces into a toxic mess, and etoposide stops the repair machinery from fixing it.
Exactly. When that cancer cell tries to divide, the damage is so catastrophic that it triggers apoptosis. The chemo makes every gray of radiation exponentially more lethal.
That makes total sense. But why stop at 45 gray? Why not blast it with a full definitive dose of 60 or 70 gray before surgery?
Because of tissue tolerance. 45 gray is the sweet spot. It's enough dose to sterilize microscopic disease at the margins, which is the whole point of preoperative treatment.
But it stops short of causing irreversible scarring.
Exactly. If you go to 60 gray, the tissue becomes wooden. You obliterate the microvasculature. When the surgeon tries to cut and sew, the tissue simply won't heal. Complications skyrocket.
And the outcomes from SWOG 94416 really proved that balance worked. Like 80% of the patients made it to surgery.
And of those who got surgery, there was a very high rate of complete R0 resections, plus a pathologic complete response rate about 29%.
Meaning, when the pathologist looked at the resected tumor, there were 0 viable cancer cells left. The chemorades wiped it out completely.
Right. And the 5-year overall survival was around 44% for the whole cohort, and even higher for those who got an R0 resection.
But we have to be honest about what this trial didn't prove. It was a single-arm phase 2 trial.
Yeah, it wasn't a randomized phase 3 trial pitting Trimodality against definitive chemoradiation.
It doesn't prove that every anatomically disastrous tumor benefits from adding surgery, especially when you look at broader trials like Intergroup 0139.
Right. That trial didn't show a clear overall survival advantage for adding surgery in unselected N2 disease.
But the exploratory findings were super interesting. The subset of patients who could get a lung-sparing lobectomy did much better than those who needed a pneumonectomy.
Yeah, the mortality from the pneumonectomies basically canceled out any survival benefit from the surgery itself.
Which again reinforces why you must specify the exact operation. This brings us back to the D in the MIND checklist. The definitive fallback imperative.
Let's use the train tracks analogy here because I think it perfectly illustrates the planning process.
Okay, let's visualize it. You start the treatment train down the track toward a surgical destination at 45 gray. Patient is getting concurrent chemo and rads.
But say at week 4, something goes wrong. The patient's heart fails a stress test. Or repeat imaging shows the tumor progressed into the spine. Surgery is canceled.
If you haven't planned ahead, you're in a terrible spot. You have to halt treatment at 45 gray, pull them off the table, do a new CT sim, redraw targets for 60 gray, and wait for physics to run a new plan.
Which takes time.
Right. But let me play devil's advocate. Why is that bad? The patient just got hammered by chemorades. Just let them rest for a week while we replan. What's the harm?
The harm is accelerated tumor repopulation. It's a biological reality.
Explain that.
For every single day you unnecessarily pause radiation, the surviving cancer cells realize they're under attack. They start dividing at an accelerated rate to replace the cells you just killed.
Wow, so you're basically throwing away the biological momentum you just spent 4 weeks building.
Exactly. A 1-week gap can significantly decrease your chance of curing them. So you don't stop the train and lay new tracks. You design the switch in advance.
So before fraction 1, your dosimetrist builds a composite plan. Phase 1 to 45 gray. Phase 2 continues seamlessly to 60 or 66 gray.
Right. If surgery gets canceled, you just flip the switch in the software. The patient comes in the next day and finishes definitive treatment without missing a beat.
That is such a vital clinical pearl. Okay, let's take you from the clinic into the dosimetry room. How are we actually contouring and planning this?
Well, it starts with simulation. And for an apical tumor, the target is right near the shoulder girdle and lower neck.
And if you've ever tried to hold your arms perfectly still above your head for 20 minutes, you know it's incredibly hard.
It's highly mobile anatomy. You need robust immobilization, custom cradles, thermoplastic masks, whatever it takes to lock them in the exact same position daily.
And you must get a treatment position in CT with IV contrast. Why is the contrast so important?
Without it, the subclavian vein, the artery, the plexus, and the tumor all just look like one big gray blob. The contrast lights up the vessels so you can physically distinguish them from the tumor.
And what about motion management? Because people think, oh, it's wedged at the apex of the chest, it's stuck against the ribs, it doesn't move.
Apical does not mean motionless. Even a shallow breath shifts that anatomy. You have to use a 4D CT.
Which acts like a video, right? It bins the CT images based on inhaling and exhaling.
Exactly. You measure exactly how far that tumor moves when they breathe, and you base your radiation margins on that reality. You don't just assume it's stuck.
Okay, now comes the trickiest part of the simulation. Fusing the dedicated MRI. We said the MRI is crucial for seeing the nerves, but there's a trap in the planning software.
Oh, a massive trap. You pull up the CT and the MRI and you hit the autofuse button. The software uses a rigid registration algorithm. It matches the spine perfectly, looks great globally, right?
Right, but globally acceptable can be locally disastrous. Think about how the patient was positioned. For the MRI, they were probably lying flat, arms down, breathing normally.
But for the planning CT, they're in a custom cradle with their arms wrenched above their head, maybe holding their breath.
The internal geometry has completely changed. The spine aligns, but the shoulder position and neck rotation mean the registration can be entirely wrong right at the edge of the tumor.
And that edge, the tumor plexus interface, is exactly where the surgeon's knife goes. It's where your dose has to be perfect.
You cannot trust the autofuse. The physician has to manually verify the fusion exactly at that soft tissue interface.
You might even have to deliberately misalign the spine and the software just to get the brachial plexus to line up perfectly.
That's fascinating. Okay, once the fusion is accurate, you build your target hierarchy. Gross tumor volume, or GTV, is first.
Right, the visible primary tumor and any involved lymph nodes.
Then the clinical target volume, the CTV. This is where you cover the microscopic interfaces, the chest wall, neural contact points, expected surgical margins.
And finally, your planning target volume, the PTV, which adds setup and motion margins.
Here is a peer-reviewed challenge for anyone at chart rounds. Point to any part of your color wash and ask, what part is gross disease, what part is microscopic risk, and what part is setup margin?
If the planner can't answer that, uncertainty is hiding in the target.
Another common mistake. Letting the CTV shrink if the tumor shrinks during induction chemo. Say it initially invaded the plexus, but chemo shrinks it away from the nerve. Do you pull the radiation target away?
Absolutely not.
Why?
Because if an interface was involved before treatment, you have to preserve that anatomical information. You're treating the original route of extension where microscopic cells are still lurking, not just the shrunken mass.
And please don't just copy the historical SWOG 94 cystifold designs from the 90s.
No, those were huge 2D rectangular fields. Modern planning uses involved field philosophy tailored to the individual, using 3D conformal, or IMRT.
IMRT is great for painting dose around complex shapes, but what are the actual dose constraints? We're balancing serial organs against parallel organs.
Right, this is a crucial radiobiological concept. A serial organ is like a single electrical cable. The spinal cord, the plexus, the esophagus.
Cut it anywhere, and the whole circuit goes dead.
Exactly. Overdose a millimeter of the spinal cord, and the patient is paralyzed below the chest. But parallel organs, like the lungs and heart, function more like a sponge.
Damage one corner, and the rest still absorbs water. You scar a small volume of lung, the rest compensates.
But this brings us back to the surgical plan. The lung constraints you accept change wildly depending on the operation.
Think about the physics. If it's a right lobectomy, they lose one lobe. They still have the rest of the right lung and the entire left lung.
But if they do a right pneumonectomy, that entire right lung is gone. The contralateral left lung becomes their entire pulmonary reserve.
So a radiation plan that allows some low-dose scatter to the left lung might be totally fine for a lobectomy.
But for pneumonectomy, it could leave them respiratorily crippled. You just irradiated the only lung tissue they have left. They'll develop pneumonitis and suffocate.
Which is why saying, we'll just decide the operation later, is mathematically unsafe. You have to know what tissue they'll rely on to survive.
Okay, so the plan is approved, patient is on the table, you're doing image-guided radiation therapy, IGRT, you take a cone beam CT. What's your match priority? Bone or soft tissue?
The treatment directive has to state this explicitly beforehand. If you align perfectly to the spine, but their shoulder shifted up a centimeter today, you'll completely miss the soft tissue tumor tracking along the plexus.
Do not improvise this complex spatial logic at the console while a scared patient is on the table.
Let's fast forward our anchor case. Patient is halfway through their 45 gray. We need to counsel them. How do you script this mid-treatment conversation?
You have to balance optimism with hard realities, I'd say. Our goal is curing this cancer. We're using chemo and rads to aggressively clean up the margins around those nerves and vessels.
But you need to understand, surgery only happens if repeat imaging shows it's safe.
Right. We are actively balancing complete tumor removal against permanent risks to your arm function, swallowing, and breathing capacity.
That sets expectations perfectly, but now they report symptoms. Week 4, they say, my right hand feels weak. Or you notice a droopy eyelid.
This is why that baseline neuro exam was crucial. You can't just brush it off as radiation edema. You have to aggressively evaluate for tumor progression into the plexus.
Okay, so we finish 45 gray, repeat imaging. The tumor board convenes, and the surgeon drops a bomb. They say, it didn't shrink enough. To get an R0 margin, I have to do a right pneumonectomy.
And this is the trap of autopilot. It is so easy for the room to just shrug and say, well, surgery was the plan, let's proceed.
But pivoting to a right pneumonectomy after high-dose induction chemoradiation requires an immediate screeching halt. Why is it so much worse than a left pneumonectomy?
It carries massive morbidity, up to 20% mortality historically. Think about the bronchial stump, the physical piece of airway that gets stapled shut after the lung is removed.
That tissue was just hammered by radiation and chemo. The microvasculature is destroyed. It's starved of blood and oxygen.
It's ischemic. Now, on the left side, the stump retracts naturally under the aortic arch. The aorta acts like a biological blanket, helping it heal.
But on the right side?
On the right side, it's naked. It's exposed directly into the massive, empty right chest cavity. There's no soft tissue to protect it.
And if that irradiated tissue fails to heal, the staples pull through. You get a bronchopleural fistula.
A direct hole connecting the trachea to the fluid-filled chest cavity. Air and fluid rush back and forth.
It causes overwhelming infections, sepsis, and it's frequently fatal. So when the surgeon says, right pneumonectomy, you stop the line.
You aggressively compare that life-threatening surgical risk against just flipping your train track switch and finishing with definitive chemoradiation to 60 gray.
You sit the patient down and have a very sober conversation. This isn't a minor tweak. It's a fundamental change in their chance of surviving the next month. Okay, let's bring it all together with our final segment, the board blitz. We're going to consolidate this into 3 traps, 6 pearls, and a rapid review. Ready?
Ready. Trap number 1. Calling any apical mass a superior sulcus tumor and jumping to trimodality therapy.
The trap is thinking location equals disease. It doesn't. You need a tissue diagnosis and proof of invasion into the chest wall or inlet structures. Penco's symptoms are clues, not pathology.
Trap number 2. Starting induction chemoradiation to see what happens without a credible surgical plan.
Don't use induction as a magic 8-ball. If there's no realistic R0 plan before fraction 1, your intent is definitive. And if you pretend it's preoperative, you won't have your fallback switch built.
In trap number 3, treating a lobectomy and a pneumonectomy as carrying equivalent surgical risk.
Any shift toward pneumonectomy, especially on the right, means you pump the brakes and reevaluate against definitive chemoradiation. Okay, 6 rapid polls, go.
Pearl 1. Superior sulcus tumor equals apical lung cancer plus tissue invasion. Pancos is clinical, not AJCC staging.
Pearl 2. The dedicated MRI of the thoracic inlet and cervical spine is mandatory. It changes T category and resectability.
Pearl 3. The nodal gate is strict. Confirm mediastinal N0 or N1 status before surgery. Proven N2 or N3 shifts you out of trimodality entirely.
Pearl 4. The reference sequence from SWOG 9416 is preoperative concurrent chemorads to 45 or 54 gray, prompt reassessment and resection only if R0 is realistic.
Pearl 5. Build your definitive radiation fallback plan before fraction 1. Avoid the treatment gap to prevent accelerated repopulation.
Pearl 6. Always favor lung-sparing lobectomies. Escalate clinical review heavily for any proposed pneumonectomy.
Awesome. Let's do the rapid review. 3 clinical scenarios. Listener, try to commit to an answer.
Question 1. Biopsy-proven epical NSCLC. CT shows chest wall invasion and subclavian contact. PT shows no distant mets, but invasive mediastinal staging and MRI have not been done. Best next step. A. Begin pre-op chemorads because chest wall invasion establishes trimodality. B. Proceed directly to surgery. C. Complete mediastinal staging and MRI before selecting therapy. D. Treat definitively with radiation because vessel contact makes it unresectable.
The answer is C. You are missing crucial information. You need mediastinal staging to confirm they aren't N2, and you need the MRI to check the plexus and see if that vessel contact is actual gross invasion.
Question 2. Patient finishes 45 gray for an N0 superior sulcus tumor. Original plan was a right lobectomy. Now surgeon says R0 requires a right pneumonectomy. Best response. A. Proceed to surgery as planned. B. Cancel all curative treatment. C. Return to tumor board to reassess pneumonectomy risk versus flipping the switch to definitive therapy. D. Deliver 60 gray to improve resectability.
The answer is C again. The risk-benefit just totally changed. A right pneumonectomy post-chemorads is incredibly dangerous. You must return to tumor board. And D is a trap. Higher dose obliterates the microvasculature.
Final question. A preoperative radiation plan uses only the planning CT. No MRI fused. Target volume only includes the shrunken post-chemo mass. Match directive is aligned to bone. No fallback plan documented. Appraisal. A. Acceptable. B. Enlarge PTV uniformly. C. Clinically unsafe. Misses high-risk anatomy, misregisters soft tissue, bad image guidance, risks treatment gap. C. Clinically unsafe. D. Acceptable if spinal cord dose is met.
Obviously C. It violates every rule we covered. You must fuse the MRI, physically verify the soft tissue interface, treat the original route of extension, and have that train track switch built before starting.
That wraps the board blitz. The lesson here is that this therapy succeeds or fails in the preparation phase. You define anatomy, confirm nodes, respect the chassis, and build a biological fallback.
And just getting the tumor out isn't the final victory. Next time, we'll look at what happens after surgery, how post-op anatomy changes your target design.
It's all about blueprints. We want medicine to be precise, but superior sulcus tumors are terrifyingly messy. If you use your MRI, your MIND checklist, and your team, you can build a blueprint that won't collapse when the surgical reality shifts.
Totally agree.
Before we go, think about this. As targeted therapies and immunotherapies achieve these miraculous complete responses, melting tumors before a scalpel is even picked up, are we approaching a future where this brutal trimodality surgery becomes entirely obsolete, where the mechanic is actually a medical oncologist modulating the immune system? Something to think about next time you see a post-chemo MRI. Get show notes and complete practice oral boards at radoncsmartlearn.com and subscribe for our next episode. Thanks for tuning in.